Good morning and welcome to Move and Bloom, a safe space where together we can grow possibilities. I'm Anna Maria Pardo and I'm super excited to welcome today Nancy Nieditz, physical therapist, pediatric Anat Baniel Method neuromovement practitioner, and Feldenkrais practitioner. Nancy is known for her calm, gentle approach with children, which is what makes her the perfect person to have here today with me to talk about something special we do in Anat Baniel Method neuromovement. We call it moving from fixing to connecting. So without further ado, welcome, Nancy. Thank you so much for being here today.
Thank you very much for having me.
It's my pleasure. And I'm super excited to hear your story. You've been a physical therapist since 1989.
I have. I was a dancer and I was a language major, Italian. I studied German, I studied Latin, Spanish. And when I graduated college in 1980, I also was interested in improv comedy, which fits into work now. And I danced and worked for Italian television and did a bunch of things for a few years and did some improv comedy in New York City because I'm from New York City. And when I was 26, I took a course with some people that I was teaching exercise class to, the Crystal Barkley Center, and they were connected with the people who wrote What Color Is Your Parachute? And I spent a week doing a course on what do you want to do? Because I could see, obviously, I wasn't going to get into Martha Graham. And I was too afraid to push through to do improv comedy. And when I was rejected from one company, I thought, okay, I'm not good enough, which is unfortunate because if I had my way, I would be on Saturday Night Live. That's my one dream that I gave up. But I did that week-long course and discovered that probably the best use of myself would be to become a physical therapist. Mm-hmm. And at age 26, I went back to school. I did all my pre-med courses and I applied to NYU and I got in. And 2.5 years later, I graduated. I graduated PT school because it took me 5 years to do everything at 31. And at first I was upset because I thought, well, I'm going to be 31 when I graduate. That's too old. And they said, well, you'll be 31 anyway. You might as well be a PT. So I did. And I wasn't super interested in becoming a physical therapist at the time because I wanted to be a dancer. I wanted to be a performer, but I did it. And it was very hard, but I was determined. And I finished. And the first day that I got to Lenox Hill Hospital and had a patient who was an above knee amputee and I helped him walk, I loved it from that moment on. And I stayed at Lenox Hill Hospital for 10 years part-time. But a year after I started at Lenox Hill, I went to do Pilates with Sean Gallagher, who's a Feldenkrais practitioner in New York. And he worked with all the dancers from ABT and New York City Ballet and the Broadway dancers. And I asked him what I should do next. And he said, if you really want to understand human locomotion, become a Feldenkrais practitioner. Yeah. So at Sarah Lawrence College, they had their, Delman Questel had their training, their first one there. And I did it every summer and Lenox Hill paid for it. And they said, as long as you come back next year, we'll pay for it. And I got the whole summer off and I did it. And so right away, starting in 1991, and I basically started Lenox Hill in 1990. I worked at the pain program and I started using Feldenkrais and I saw that it was so efficacious and that my patients did so well. And every doctor in the hospital that had a problem would come to me because they could see the difference between traditional PT and Feldenkrais work. So that's how that started. And during my training, we had some trainers working with children with CP and that really caught my eye. And I thought, that's what I want to do. So I joined Life Start, which was one of the first early intervention programs at all in 1995. And it was in our hospital. And I started to work with kids. So I contacted Marcy Lindheimer, who's an ABM trainer. Yeah. And she became my mentor. And I would bring children to her and I would say, what do I do? And she would show me everything she knew. in 1999 or 98, she told me to go do a knots training in California. I did the first one, and then I couldn't do the rest of them because of my schedule. And I learned so much that I went back again in 2000, did another baby training. And then Marcy said, Anat's going to be here in 2006 in New York, do the whole training. So I did. It was in segments of 12 days, I think.
Mhm.
And then I brought all the kids from early intervention to do the practicum. And so I learned so much that year, and then have just been doing, only working with children since about 2000. I've just been working with kids about almost like 1998. And I also 15 years ago started to work at a clinic in upstate New York, Curious Joel. And it's a HQFC, a federally qualified health center. So I started 1 day a week. Now I'm there 3 days a week, and I see about an average of 13 babies every day that I'm there, 3 days a week.
That's fantastic. I'm really curious about that because I started at a volunteers in medicine that turned into an FQHC. So I'm curious how they see your work. In other words, do they love it because you're a PT and then you qualify under that qualification, or would they have welcomed you as a Feldenkrais practitioner?
I started there in somebody's basement, and then a few months later, they asked me to join the FQHC. And because I'm a PT, I was able to work there. It has to be PT, RN, OT, speech, one of those.
Yeah. They're so lucky to have you.
Thank you. But they love it because I evaluate as a PT, and I can make judgments about what does the child need, or what doesn't. The child might not need anything. And because it's a federally funded health clinic, a lot of times I'll get kids coming in because a parent is concerned, and the nice thing is they don't have to worry about, do I have to pay for this? It's mostly paid for through Medicaid, because 93% of the folks are on Medicaid or one of the HMOs of Medicaid. So I do see a lot of kids who don't need anything, and I let them know right away, we're not doing anything. There's nothing, if your child isn't walking at 15 months, this isn't a problem, because they're on the trajectory for walking. I use standardized tests to evaluate, but a lot of times those aren't even relevant, because either a child is so delayed that it's not a relevant test to use, or the child is just fine and they're a little delayed and they're going to get there anyway. And I'm not going to waste resources and time working with a child that's holding on to things and walking around. If they're 16 months, they're going to walk. And I say, if in a few months you're still having trouble, come back.
Right. So do you think part of your ability to be more easy with that kind of trajectory comes your Feldenkrais and neuromovement training?
I think because, and I think that what Moshe Feldenkrais really tried to impart in people was that the normal that we think of is not necessarily normal. And a lot of children will maybe talk early, but not, their brain is so involved with talking, or they'll use their hands very well early, but not necessarily do their gross motor things early. So I think that also, all of the talk that I've thought of from the beginning of my Feldenkrais training is, don't force people to fit into a certain box. And that's not necessarily what's helpful. But you have to, you want to know from a professional, is this okay? And I think it's important to know what's okay, and to see, no, but everything else is fine. The muscle tone is fine. The reflexes are fine.
Yeah.
The balance reactions are fine. They're going to be okay.
Wonderful.
So.
Wonderful. So you've got this sort of dual thing going where you can evaluate like a PT and have patients like a Feldenkrais or neuromovement practitioner. And so you see your people at the FQHC. Tell us the rest of the story.
So I do that. And then I also have a home practice in New Jersey. And I see children who have issues in my area. meaning my area of New Jersey, or sometimes I do home care in New York City because I'm from there. And there's a practice that always refers to me because they feel the difference. The parents feel the difference between many traditional PTs and what we're doing as neuromovement professionals. And I think that the main difference is that, as you were saying, we meet the child where they are, and we don't just go in there and try to change them. And what I like to think about when I teach my Torticollis course and I talk to PTs, because I have to meet them where they are, is I say the history of physical therapy is in Sweden, and it comes from getting people after the war to be rehabilitated. And it was a wonderful idea of getting people to move as opposed to just being, or after polio, people would be put into an iron lung and they wouldn't move, and they were told not to move. And the physical therapist said, no, you've got to get going. And that's actually going to help you more. And as a matter of fact, when you are in the hospital and you have a joint replacement, you have a hip replacement, a knee replacement, you have to be up the next day because they don't want you to get a blood clot. They want you to get moving. They want the air to keep, and so the PTs are responsible for getting people to move. But what I think the place where neuromovement and Feldenkrais come in is that you can't just force somebody to move, and you can't make them move if they can't move. And one of the things that Anat always says is, if they could, they would. And so
Exactly.
when you work with children who have a difficulty, if they can't roll, if they can't come to sit, if they can't stand up, what PTs do in general is they do those things for the child in order to get them to do it. And a lot of it comes from our desire, the parents' desire to see a change. And so by imposing on the child this way of doing something, you're actually frustrating them because they can't do it. So what we do as a Feldenkrais practitioner is we create conditions to make the next thing easy. And an example of that, and for me, this was really wonderful. Marcy and I had a child about 20 years ago who had terrible seizure disorder, like the worst I've ever seen. And she couldn't do anything, and she was a year old. We tried and we tried, and we finally said to the parents, go see Anat in California, and they did. And what Anat discovered was that the child loved to eat. She just loved to eat. So Anat said, okay, in order to get her brain to wake up and realize that she has something to do with the world, that what she does makes a difference, she had her start to just touch the bottle. And as soon as she touched the bottle, she gave it to her. And then she upped the ante to the point where she, by the end, was holding her bottle, so that she knew that something that she did made the difference. And she was alive, and she had some execution over what happened in her life. And that was like a real light bulb for us. So the conditions were, she created the conditions to be so simple that just by touching the bottle, she got it, to the point where using two hands together in midline, she could bring the bottle to her. And that was the beginning of her learning how to roll and come up to sit and stand. And that is exactly what we try to do. If a child can't roll, we work with the child inside lying on their back, through the spine, through the hips, and we make it so easy that the next thing they do will be that. And we do it in different ways. And the reason that we do it in different ways is we want to create new synapses in the brain. And the best way to describe this for me is when, if you've ever done your hair and you want to do the back of your hair, and you look in the mirror and you put a mirror behind you and you start to do your hair, what you find is that you can't figure out which hand is which. And that's exactly what a lot of children feel. Like, I'll say to a parent, you think it's so easy to grab that toy, but it isn't. They don't know how to grab that toy. They have no connection in their brain that knows how to go from here to here. So we have to make it so simple that the next thing they're going to do is grab that toy. And that's constantly what we do. We keep finding the easiest, next easiest, next easiest. And that's why we start a lot of times even just in the stroller or in the mother's lap or the caregiver's lap,
Right.
because we don't want to just freak them out. And so
Make them not want to learn. Yeah, you're bringing up stuff for me that's really interesting. And I want to back up and say that I think something you said is really important, creating the conditions in the brain that allow for change to happen. Because one thing I noted in the training, so my mother's an educator, and so of course, a lot of the household talk was about education. And I think, so when I went into the training and I saw how Anat was training, I said, wow, she really understands how people learn. There's just so many elements in the training itself and elements then in how we interact with people that are coming from this place of a deep respect for how our dynamic system actually learns. And so I know you talk about the next easiest thing in education. It might be called the zone of proximal development, so it's coming at it from a different place, but it's brilliant. And what I love about it is that, sure, people talk about it in education. They might have talked about it in my nursing training, in your PT training, but then how it's executed is completely different. I feel like when people go from theory to practice, they lose something that isn't lost in Feldenkrais and neuromovement work. What's your take on that?
Well, what I wanted to say from before, just to circle around, is the difference between physical therapy and psychology, let's say, or
Sure.
When people go and get psychotherapy. When somebody comes in and says, I'm deeply afraid of spiders, for example, the psychologist or social worker doesn't say, that's ridiculous. What they say is, tell me more. That's really interesting. I can understand that. I really get it. And when somebody gets you, you feel relaxed. So that when I teach, I try to tell people, look, if your child has torticollis, a silly thing, just, a tilt, support the tilt and say, I get why you want to be here. And this makes a lot of sense. And why wouldn't you want to be here? I would want to be here too if I were you. And then the nervous system can relax. There's nothing better in any interaction than if you tell somebody something and they get it. And even if you don't agree with them, if you support what they say, they can relax. And I think that is that's the beginning. That's kind of like number one. And that's what Anat does with all the children, that's what every Feldenkrais person does. That's what David Burson does when he works with an adult. And the genius is, you see him doing functional integration, and he has somebody on the table and they're completely twisted and he supports the twist. And when you do that to somebody, miracles happen because you're meeting them exactly where they are. And you're saying, that's really fine. And let's see if we can do something else. So, when you came into the training and you could see you're lying on the floor and you're doing these movements and nobody's saying, that's ridiculous, why are you doing it that way? You kind of go, okay, well, I'm discovering, or maybe they'll come over and gently show you a different place to move from, or make a constraint that makes you work a different place. And knowing all of what those things are is what makes such a big change.
Right. And for me, one thing that really stood out, like in education, they talk about scaffolding, and it's not very elegantly done most times. It's a great idea, and there's often this element of it that it's not, oh yeah, we provide lots of entry points for people wherever they are, but it's not truly meeting people where they are. Whereas within the neuromovement system, you feel truly supported exactly where you are.
That is, I find it so interesting because I'll get a child on the table, maybe they're blind or they've had seizures, and I'll try to connect with them somewhere and they can't connect there. So I'll hold the child and maybe just stroke the cheek and let them turn and do that, the cheek, then the jaw, then the head, the neck, and in ways that it's so simple for them to do it that they're never going to feel frustrated.
Beautiful. Beautiful.
And that's the key. And for example, I remember Larry Goldfarb, a trainer for Feldenkrais, talking about the knee and how it's just a place in between the hip and the foot and the ankle. And so when PTs work with people who've had knee replacements, the goal is to get 90 degrees of flexion in the knee, which is very painful and very difficult. So what we try to do at that point is, instead of just bending the knee, because what happens is if you keep doing the thing that's really difficult for somebody, what happens is, it's like if I run into a wall and every time I run into that wall, I hit my head, then I'm going to back up. So if you take somebody's knee and you keep insisting on bending it, you're just going to get them straightening it more. So you're doing the opposite. So what we try to do is, okay, well, what happens in the hip? What happens in the ankle? Let's move those places where the person isn't even focused. What happens in the chest? What happens in the back? And then they start to move those places and automatically the knee will move. So it's those subtle points of, because we're talking about pain, real pain. And so for babies, it might not be pain so much, but it's just incredible difficulty. So we just have to keep finding and I tell the parents, it's my job to figure out, it's our jobs to figure out how to make it easy for the baby. It's not their job to perform. And that's the difference. They don't have to do anything. Or parents will say to me, I had a girl who came in with torticollis, and it happened, she was 8 years old. It happened after having a virus. So it was probably Grisel syndrome, and she came in and she was completely stuck. And the mother said, I think it's behavioral. I think you just have to work through it. And I looked at her and I did some different things. I took out some lollipops. I didn't do anything passively because I was very concerned. And when I could see that there was nothing changing and that there was no way she was going to move her neck, I sent her back to the pediatrician, who sent her to the neurosurgeon, who sent her to the hospital, who they actually had a C1, C2 subluxation, which is at the top of the neck. And it was so bad that they had to put her in traction. That didn't work. And then they had to do halo traction for 6 weeks to literally. Now, if I had manipulated her, it would have been a disaster, and it would have been exactly the wrong thing to do. So when you see somebody who's really stuck, you have to make a determination that you are not going to fix this. So, and I thank God I didn't.
Yeah.
Who knows what would have happened? But the idea is that, people are doing things for a reason. They're not just doing, there are some psychological situations and that has to be explored. But you don't make that determination until you figured out every single physical thing that it could be, because really that's a shame to blame somebody for something that's happening when it really isn't anything they can do anything about.
Right. And even if it was, how does the blame serve us?
Right. And how do you support them in a way that they don't need to do that anymore and they can move to the next level?
Right. So here's an interesting one for you. I'm curious about how you talk to parents and families about how real world arguments, right? Because this is a very gentle, ethical approach. And for some people, that really comes up against some beliefs about, but you have to know how to be in the real world. Have you come up against this at all?
So I have a lot of people who have therapists that they can see, let's say, through their insurance or through early intervention, and it's free or it costs very little. And they like the person, they don't want to hurt their feelings. And for some of the people that they work with, they're excellent and they're getting somewhere, although they wouldn't usually be coming to me if it were working so well. And what I say is, and this is something Marcy taught me, she said, why don't you just tell them to take a break for a few weeks and just do some neuromovement and see what happens. Just see if, give it some time. And I don't always get to work in intensives because of my schedule and the child's schedule and insurance. But when people do work, let's say 4 days, twice a day, they have the opportunity to really see what can change. And so that's a nice way of not telling them give up everything else, but say,
Mhm.
why don't you see what happens? And
Right.
that helps. I obviously have lots of situations where a child will be seeing a therapist who's very forceful and
Mhm.
very, I have a lot of kids that come to me because the therapist said, okay, they're not going to crawl. We're just going to get them up to stand and walk, sit to stand, sit to stand. And what I do is I say, I actually think we could get to crawling. And don't worry about the walking for now because nobody ever asked you how old you were when you learned how to walk. Nobody. Like nobody even cares where I went to college, and I thought it was the most important thing in the world. And what people care about is what you're doing right now for them and how you're helping them and if you can help them. And if your child skips crawling, skips rolling, skips all of these things and doesn't even know how to fall, and you just get them up to walk, then for the rest of their lives, they're going to walk. They're never going to go back to crawling, but they're going to fall all the time. And there's really high potential for hurting themselves. Because if you don't know how to fall correctly, you're going to break your head. So I always say, think about it this way, that
Mhm.
it's going to take some time, but it's probably going to be, you're going to get a better result in the end. And that is probably the place where people get the most stuck when it comes to working with children, especially children with CP or hemiplegia or low tone or muscular dystrophy or whatever big situations arise, is to just try to get them to calm down and not worry about getting up and walking, even though that's
Right.
what you want.
So working, and perhaps you don't work through insurance, but I think part of what creates this sense of urgency for both parents and practitioners who accept insurance is that, but we've got to do it before the insurance runs out. The insurance said we only have this long. How do you handle that?
Um, well, I do a few different things. I'm an out-of-network provider
Mhm.
privately. So people, if they have out-of-network benefits, they can see me. At the clinic, they can use in-network benefits. So that's not what most people can do. Um, so if somebody has out-of-network benefits and it's a long-term case, I'll tell them, when you get paid, you can pay me. That's one scenario. I also say, your child is going to cost a lot of money. College is going to be expensive. So if you don't fix this now, 0 to 3, it's going to be it. Then for the rest of their lives, they're going to have to live with this deficit. So it's probably worth just spending the money now and getting it over with. And
Yeah.
um, I try to make it affordable. I have a sliding scale. I think
Sure.
it's important for people to do that.
Yes.
And I mean, and I say to people, if I were hanging the wallpaper in your house, I would tell you, this is my feet and take it or leave it. But when I'm working with children, I feel incumbent that I help them out because it's a child's life.
Right.
So,
Yeah, that's interesting to me because I brought this up because I feel like um, a lot of us who have to work within the medical system are forced to move to fixing because of the way the system works. And so we have to be pretty subversive in how we implement, uh, how we practice so that we can move from fixing to connecting. And something you said made me think that actually part of it is helping people move, our students move to feeling safe, right? Because when insurance threatens to withhold something or threatens that something's going to be gone, that creates a sense of fear. And then you provide the sliding scale, and that provides a sense of safety. So we're coming back to just the essentials of the work. You need to feel safe and you really need to connect. And I love what you said about really investing in long-term future, right?
Yeah. I mean, if you can, there's so much that happens the first 3 years, so many connections that happen above and beyond any other time in life. If you can fix those things in the beginning,
Yeah.
that's really important. And the other thing that I do that maybe a lot of people don't do is I really try to educate the parents to have a few things to do every time they leave.
Mhm.
So I don't just say, I'm the only one who can help. I'll give them some things to do that are quite simple and let them work with those. And I think it gives them a feeling of reassurance. And I don't try to act like I'm the only one who can do it. Now, certain things, yeah, I mean, I wouldn't expect them to do, but I do try to give them, I have them take little videos. And then for Torticollis, I give them a booklet based on what their child has.
Fabulous.
But I do
And,
think it's important. Yeah.
and that's kind of your wheelhouse, the Torticollis, yes?
Yeah.
Tell
Yeah.
us about your course.
Well, I've been doing early intervention since 95, and a lot of the cases were torticollis. And when you see a child, at least in New York City, for New York State, you get the child for 6 months. And I would get the child for 6 months, but I would be finished in a month. And so then the parents would say, oh, but
You've cut out, Nancy. I can't hear you.
oh,
Okay, there you go.
okay. What I tell people is so early intervention is for 6 months. I would see them for a month and they'd get better. So I could see that I was quite good with torticollis. It wasn't a difficult thing to fix. And it usually isn't. It's rare that it's difficult. And with the kinds of things that I was doing, I could actually show the parents. And then I was getting these flyers in the mail about torticollis courses. And I thought I could teach a probably better torticollis course.
Yeah.
So I actually was lucky enough to have somebody who was a PhD who showed me exactly what I had to do. And it was a lot. It was about 60 hours of putting together references and work and bibliography and research and really studying everything I could about torticollis and all the causes and all the things that it isn't. It could be all of the dangers of what you shouldn't do, which is why I knew not to touch this girl who probably had Grisel syndrome. And I put it together and I got lots of videos. And that was probably the hardest thing, was getting the permission to use the videos from my patients. And then I put together a one-day course for physical therapists and occupational therapists. And in 2010, I started to teach all around the country and then taught it abroad also. And people, what they liked the most was watching me work with the babies, because I would try to get real babies to work with. And they were always surprised at how gentle it was, but it worked. And they could see it work right away. And so then I put online my home program, and people for $15 can get this, right side, left side based on age. And it really is quite easy to do. And that's, so I see kids once or twice and that it's finished. And I try to teach other practitioners. And I think that one of the reasons why in general, the way that people work is from the work that I've taught, because I've taught it so many times around the country that it really caught on. And so people tend to be less forcing the child into passive range of motion and making them cry. And although I did have a child yesterday that I evaluated who's had therapy for a year and he's still really tight. And I said, does he cry during the session? And he does. And so then you get, if a child's tilted like this and you keep stretching them and they don't want to be stretched, they're going to do this. So that's a really good example of not meeting the child where they are, and it doesn't get better.
Makes it worse.
Yeah, it makes it much worse. And the child feels like so betrayed by the parents and by the therapist, because, it's one thing to give a child a shot, that they have to get a vaccine. And then there's another that you're forcing them into these horrific positions.
Over and over again.
Yeah, over and over again. Yeah. And that's how it is. Even some speech therapists will manipulate the child's mouth, and I'm watching the parents try to do it, and they're just forcing their fingers in, and the kids are crying, and their gag reflexes in the front, and the kids are vomiting, and it's like that's what they do, and they think that it's like the touch that we learn in neuromovement, ABM, Feldenkrais is so different than anything else.
Right. And what I want to interject here is that a lot of these parents and therapists are very well-meaning, and they were just they just haven't yet been introduced to a way of thinking where they're afraid of failing the child, right? They haven't yet been introduced to a different way of thinking. They don't understand that another way could work. And here's the line I like to use, which is, if you could accomplish the same thing in a gentler, easier, more ethical fashion, why wouldn't you? Why wouldn't you? I'd take that choice. So yeah, rebounding, you do too much of one thing and you're going to protect.
Right, right. You're going to get a stretch reflex. And the other thing is, what I find astonishing is a parent has no idea. Like, I'll show the parent every time I see them, this is how I touch the child. And they're always like, really? That's all you did? Because if I let them do to my hand what they do to the baby's neck, I would scream my head off too. I mean, it's insane. And you can easily damage somebody's neck by overstretching them or pulling nerves, or, I mean, it's incredible. And the kids will be screaming their heads off and turning blue, and they do it anyway. And it's, and I think that the issue is that when I went to NYU, they taught to the exam. I mean, it was a lot of information that we had to get in, and you have to learn it to get past your license. And it wasn't a lot about the quality of how you're moving somebody. And I think it's very hard, though, to ask people who become doctor of physical therapy, because they take another, 9 months or something and get and they do some sort of a small, I mean, it's not a PhD, but they're, doctors of physical therapy now is the only way to do it. Now they've spent 5 years, they have $150,000 loan. And now you say, you know what, you should do neuromovement or Feldenkrais. It's very hard to convince people to. But I will say that any physical therapist or occupational therapist I know who does do the training always ends up just using that work because it's brilliant. And I tell people it's much more refined. And it's also, I've taken 4 more, 8 more months altogether, full time to learn something different. So why wouldn't I know more? And if they want to do that, that's fine. But this is active work in learning how to move somebody and help somebody move better.
Yeah. Or
be more whatever they need to be in the world.
Yeah. Yeah, definitely. If I was a PT, I'd be all over this work. So you mentioned the families not having the refinement of touch necessarily, so you have to coach them through that. What other advice do you have for parents when they're choosing a PT or communicating with their team?
I think that if somebody ever says, I don't care if the baby cries, I have to do this work. We have to do it. This is the only way they're going to learn. I would run away. When I actually tell everybody this, when you look for a doctor, whether they're somebody who accepts Medicaid or accepts your insurance, whatever it is, after you find out who's on your plan, now go to Google and look at their reviews. And if they get anything less than a 4.4, stay away. Mm-hmm. That's what I think, because there's a reason why people say, I love this doctor. They listen to me, they get a 4.9, I mean, it's rare. Sometimes somebody will talk dirt about someone, but in general, you're going to get an idea. And I can't tell you, I mean, I have a team of people I work with in New York and New Jersey who are just fabulous. And some of them take Medicaid and I'm thrilled. And that's who I send people to. And so I always tell people, make sure that this person has really good reviews and people like them. And just always make sure to find out what the problem is before you work with it, and make sure that that's really the problem.
Yep.
Get a really good evaluation. And if you have a doubt, then follow your doubt and go to somebody else and get a second opinion.
Yeah, that's fabulous.
You can always find somebody good in your plan, but you just have to do the research. And I always do that, always, for myself and for patients.
Brilliant. Spend the time up front instead of crying about it later. Yeah, that's brilliant, and it reminds me of the story Anat always tell us about Feldenkrais, who had a family come in flying from Germany. I don't know if you remember this story to um, have Feldenkrais see their daughter. And for the entire first session, he just sat there looking at the child and thinking, asking a question or two of the parents, but he did not lay a hand on the child. Same thing for the second session, until finally he figured out, but he wasn't going to touch that child until he figured out what was going on. He wasn't going to jump in and start doing things. He was going to clearly define the problem first.
Well, I have an interesting story. I had a girl come in who was walking on her, like somebody who had horrific CP. She was 8 years old and she couldn't put heel to toe. And I said to the mother, where her AFOs, does she have braces? She said, no. And I thought, well, she's terribly undertreated. And then I came to find out that this was something new that happened. What happened is at school, a girl who had CP was bullying her. And she developed, and then everybody started to bully her. And then she developed this walk. So I thought, oh, this is psychological. And I started to work with her and try different ways of getting her to put her heels down and connect with her pelvis. And I worked with her very gently. And I started to get frustrated because, well, and then I suggested they go talk to a psychologist. And well, a bunch of sessions later, and seeing Dr. Jordan, who just retired mostly, but he also is doing Zoom sessions. But it turns out that she ended up having a neurological problem. I forget the name of it, but it'll come to me. And it was not psychological. And that was a really, really important moment for me to realize that, and it needed to be treated in the basal ganglia with things that you use for patients who have Parkinson's. And it was a very serious neurological disturbance. So, you know, we don't always know, but it takes time. And I was getting frustrated, and I thought, this is not good for me to be frustrated, because I thought, well, we're talking about this girl who had CP and about the bullying. It didn't make a difference. So you have to know what the child's going through before you make a decision.
Yeah, and it worked out for you in part because you were open to the possibility that there was more going on, that there was something different going on. You hadn't made up your mind definitively one way or another. You had an idea, but when that idea didn't work out, you said, okay. So you were flexible in your approach. Again, you were connecting rather than looking to fix.
Right.
Yeah.
And I think it's important, you know, connect, and also, but use your very specific thinking mind about what is going on. And that's really essential.
Yeah.
But you're never going to hurt the child if you connect for a long time until you can figure out what it is that you could do to help them.
Absolutely.
So,
absolutely. Well, your clients are so lucky to have you. And I've been so lucky to have you here on the show. Thank you. Is there anything else you'd like to say before we sign off?
No, I just, you have, if you have any doubts about what you're feeling, always go with your gut. That's what I think.
I love it.
Yeah.
I love it. And if your gut is telling you to get in touch with Nancy when this conversation is live, she can drop her details in the comments for you to be able to find her quickly and easily.
Thank you. Thank you.
Yeah. Thank you so much.
Have a wonderful day. Bye-bye.
Bye.